some example of a patient with, so this is a patient with a normal heart. Okay, so as you can see, this is a sweep that goes from the apex of the heart up until the parasagittal view of the aortic arch. And what we can see is that there is no significant disproportion. So the superior in this clip ventricle is the left. So we can see the two papillary muscle. There is a mitral valve which is bileaflet, so there is no trileaflet AV valve, no cleft. There are normally spaced papillary muscle, no disproportion. Without color, I don't see any ventricular septal defect. We have a nice and widely open RVOT, and then we have a beautiful, good size aortic arch with normal spatial relationship between the branching pattern. And I'm just going to go frame by frame and pause it here. So as you can see, this is what you want to see, a normal aortic arch, some discrepancy in size between the isthmus and the descending aorta. Okay, and this is the same patient with the color. So nice and smooth color. There is no flow acceleration in this with this velocity. All good, all normal. And on the left-hand side here, we can see a normal aortic arch, as I said, with baby with coarctation. So in the middle panel, you have an abnormal angle of the insertion of the aorta into the ductal arch. We see posterior shelf here, so very high suspicion for coarctation in this baby. I think there is also increased distance between the left common carotid and left subclavian artery. On the right-hand side, there is the arch hypoplasia, I think. I don't think there is a posterior shelf that can be identified here. Okay? Again, some increased distance between the left common carotid and left subclavian artery. And this is what I was talking about. So some author assessed the the distance between the left common carotid and left subclavian artery. There is a value which has been assessed above 28 weeks, and babies with coarctation can have an increased distance between the two vessels. Okay, and then again, another group of authors assessed the angle between the aortic arch and the ductal arch, and a more acute angle than to be seen in baby with coarctation. So not all of these findings are always present in every patient. Okay, some patients present only with hypoplasia, some patients present only with disproportion, no posterior shelf, normal Doppler. So, and that's where the challenge begins, and where the patient then needs to be stratified, and the risk of coarctation may not be high, and prostaglandin are not started, but rather postnatal assessment in the first day or first hours of life. And this is a recent patient of mine that I have, which I put because I think it's very clear here that the aortic arch is very abnormal. This is with power Doppler because I wanted to highlight how tortuous and hypoplastic the ascending aorta is. It's a sort of angulated arch. Gothic, I think there is some flow persistent that start after the first branch, very clear posterior shelf, diffuse arch hypoplasia. This baby also has a bilateral superior vena cava with a left SVC to the coronary sinus. And I am following up this baby. There was some small and narrow LVOT as well. The mitral valve presents a degree of hypoplasia. So I don't know how we will eventually manage this baby after birth, but the pregnancy is still ongoing. And when patient present like that, it is very easy. So we can see a very diffuse arch hypoplasia. The arch is the same size of the common carotid and left subclavian arteries. It's posterior shelf, very obvious disproportion, and the increased distance between these two vessels. This is an example of a slow flow. It was an early scan at 16 weeks. We call it just flow because I decreased the grayscale just to visualize the vessel anatomy. It was quite useful. I think there is a very obvious disproportion there.